talk would be on exploring the renal benefits of SGLT2 inhibitor and GLP-1 receptor agonist integration. So whether they provide additive benefit or maybe even they have a synergistic beneficial effect on renal outcome. The slide's not moving. So let me walk you through this very illustrative case report. SGLT2 inhibitor and GLP-1 receptor agonist combination substantially improved renal function in a patient with type 2 diabetes. 72-year-old type 2 diabetic since the age of 54, microalbuminuria detected at the age of 64. While HbA1c had been kept below 7%, eGFR was declining rapidly. At 70 years of age, the eGFR dropped below 50. A renal biopsy revealed diabetic nephropathy. A combination of SGLT2 inhibitor and GLP-1 receptor agonist was initiated, which substantially improved his eGFR and urinary albumin excretion, and the renoprotective effect persisted for the 2-year study period. So these findings suggest that SGLT2 inhibitor and GLP-1 receptor agonist can additively improve renal function in persons with type 2 diabetes. So interesting case report, and now let's take a look at what the literature tells us. In this recent meta-analysis, we actually looked at what happens to cardiovascular and non-cardiovascular mortality in type 2 diabetes when you add GLP-1 receptor agonist on pre-existing therapy, which included SGLT2 inhibitors. So on your left, you can see randomization to GLP-1 receptor agonist treatment was associated with a reduced risk of both cardiovascular death and non-cardiovascular death, which included renal death. On the right, GLP-1 receptor agonist treatment also reduced all-cause mortality, which of course was inclusive of renal death. In the last session which I was chairing, there was a question on how to define renal death. So this has always been perplexing. I scanned the literature on the CANVAS trial and then the subsequent the renal outcome studies involving the SGLT2 inhibitors and the GLP-1 receptor agonists. The renal death was actually defined as people dying without an identifiable cardiovascular cause like atherosclerotic cardiovascular disease, cardiac arrhythmia, advanced heart failure, and in presence of infections while undergoing dialysis or those who had undergone transplantation. So again, infection may be due to immunosuppression or whatever. So infection was thought to be a major cause, direct cause of renal death in people on dialysis, hemodialysis, peritoneal dialysis, and of course, transplantation. So this forest plot tells us how effective this combination is in terms of improving renal outcome. So here you can see end-stage renal disease. So SGLT2 and GLP-1 combination. The pointer is not showing up there. Okay, so even this is not, yeah. So you can see here a very impressive improvement in renal outcome in end-stage renal disease with this combination, and also preventing decline of eGFR by more than 50%, which is considered a standard parameter to evaluate the renal safety or renal benefits of both SGLT2 inhibitors and the GLP-1 receptor agonists. So significant improvement with this combination. So GLP-1 RAs may exert beneficial cardio-nephroprotective outcomes through a combination of indirect and direct effects. Of the indirect effects, of course, you have improved glycemic control, better blood pressure control with this group of agents, and weight control. Talking about the direct effects, there is increased natriuresis. So Dr. Sudipta was alluding to this. If you increase the delivery of sodium to the distal part of the renal tubule, proximal tubule, where macula densa is present. So macula densa actually senses this sodium, increased sodium delivery, and sends molecular chemical signals to the afferent arteriole, by which there is a fall in interglomerular pressure, and which kind of tries to protect the glomerulus. And this effect is actually synergistic with the use of the effect of ARBs on the afferent arteriole. And then there are multiple studies now to show that both GLP-1 RAs and SGLT2Is, they reduce not only systemic inflammation, but also inflammation and fibrosis in the kidneys by regulating oxidative stress and renal fibrosis. Shamanti was talking of TGF-beta, complex mechanisms. If time permits, maybe we can discuss during the Q&A, but very interesting mechanistic data are now available. The FLOW trial, as you all know, was a dedicated renal outcome trial involving the GLP-1 receptor agonists. And here on the right, you can see around 16% of the patients had SGLT2 inhibitor on board. So that subgroup actually was treated with a combination of GLP-1 RA and SGLT2 inhibitor. So what happened? 24% lower risk of the composite primary outcome, consistent risk reductions for kidney disease component of the primary outcome, and consistent risk reductions across pre-specified participant subgroups, so which included the SGLT2 inhibitor subgroup also. So the combination actually provided additional benefit in the FLOW trial. Now, what happens in terms of eGFR loss when you combine an SGLT2I with a GLP-1 RA? Now, no matter what renoprotective agent you use, be it ARB, mineralocorticoid receptor antagonist, or even the SGLT2Is, you get an initial dip in eGFR in the first 3 months, which eventually tends to normalize over time. Very interestingly, GLP-1 RAs, they do not produce that initial dip. And this has been now shown in renal outcome trials. Now, when you combine SGLT2I with GLP-1 RA, whether GLP-1 RA takes care of the initial dip induced by SGLT2 is not known at this point of time. But it will be interesting to look into that effect of GLP-1 RA on eGFR in someone who is already on an SGLT2 inhibitor. So these are the highlights from the FLOW trial, and the investigators now propose that the 4 pillars of therapy, renoprotective intervention, should be a RAS blocker, SGLT2 inhibitor, a non-steroidal MRA, and semaglutide. So this is the proposed 4 pillars of treatment to provide optimal renal protection in people with type 2 diabetes. So to summarize, the combination of SGLT2 inhibitors and GLP-1 receptor agonists can reduce the risk of serious renal events by 57% compared to either drug alone. This combination can significantly improve renal function in patients with type 2 diabetes. The combination can also have additive effects on lowering HbA1c levels, systolic blood pressure, and body weight. And this is particularly important in young people with type 2 diabetes. You know, the biggest driver of stroke in the young having type 2 diabetes are these 3: HbA1c, systolic blood pressure, and body weight. So this combination of SGLT2I and GLP-1RA, they take care of all the three major risk factors for cerebrovascular and cardiovascular disease in young people with type 2 diabetes. Both these combinations can have direct renoprotective effects by suppressing inflammatory responses, preventing apoptosis, and inhibiting oxidative injury. However, factors such as costs, coverage, and toxicity profile may delay the combination of SGLT2 inhibitors and GLP-1 receptor agonists from becoming a common practice, more so in our country where medical expenses are mostly borne as out-of-pocket expenditure. Thank you for listening.